Thanks. So this is my disclosures. Our aims with ACL reconstruction is, as you know, to restore knee laxity, normalize biomechanics, in order to be able to give our patients the possibility to a safe return to previous or desired activity levels without attaining new injuries. But we have problems still. There is place for improvement. We did this study a few years ago, and we could see that residual laxity is very common. With over 5,000 patients, where we looked at KT1000 at 6 months, we could see that 35% had a side-to-side difference of more than 2 millimeters. And we also have a problem with high rates of re-ruptures. This is from the Swedish Knee Ligament Register about revision surgery. And 5% almost will have a revision surgery within 5 years after the primary reconstruction. And we know that the re-rupture rate is far much higher. And in some subgroups, as for example in female soccer players, that is very common in Sweden, the re-rupture rates are over 20%. In the literature, KOOS, the PROM, under 44 is often regarded as a treatment failure. And if we look in our registry, 30% of our patients would then be regarded as a treatment failure. So the question is if this concept could contribute to better outcomes. We have different challenges with ACL surgery and rehabilitation. One is to optimize the rehab without compromising graft incorporation and maturation. We know that the ligamentization process is a very slow process. First, it's very weak in the tunnels, and then intraarticularly after a few months. And the total remodeling process probably exceeds 2 years, and no one knows for sure when it's good enough. But we can't protect the graft too much, since mechanical loading is also important for the healing process. But on the other hand, overloading could also lead to impaired graft healing. So we need to find the best perfect balance between the load to which the graft is subjected and the gradual maturation of the graft. And this is not easy. In Sweden, we have a good word for this. We call it lagom. Lagom is not too little, not too much, just right. The internal brace concept is like this. We used to put the suture tape around the graft. But if you do it like this, you will not have an independent load distribution, and probably you might protect the graft too much. Another way to do it is to put the tape around the portable button instead. And if you then fix the tape in extension and the graft in some kind of flexion, depending on isometry, the graft will be the primary stabilizer through the entire range of motion. And it will then look like this. You fix the suture tape first in full extension, and then you fix the graft in flexion, depending on the isometry of your construct. So if we look at this, are there any biomechanical benefits to add this suture tape? A great study was done by Bachmeier, and they defined the ACL function zone. And they could show that the ACL transitions from slack to strained at about 35 to 40 degrees of flexion. And in their study, they tried to mimic the rehab period after the ACL reconstruction. And they could show that with internal brace, the function zone of the graft shifted towards a more normal behavior. And it did so even more if you had a weak tendon defined as a tendon below 8 millimeters. And the same applies for the quad tendon. With internal brace, the quad tendon will endure almost twice as high load as without the internal brace. But one important thing to take in mind is that biomechanics does not take into account biologics. So we need to ask ourselves, are there any negative effects of adding a suture tape? Is there any clinical proof that adding a suture tape to the graft is efficient? And which grafts would benefit from this? And does it reduce re-tear rates? And there are no clear answers to these questions, but there are something that we could discuss about it. We have used suture tapes in the body for a long time, in the shoulder, for example, and there are no apparent negative effects of that. And this study also shows that it has good biocompatibility and no apparent negative effects if you use it intra-articularly. The next question is whether there are any clinical proofs. There are not much studies looking at that. This is the first one. They had 30 patients only. And what they could show was that they had small differences in favor of a suture tape with the PROMs, the subjective outcome, and no other differences. We tried to do a study at our clinic as well that was published this year, half a year ago. And we had a prospective inclusion, but with historical matched controls. We included 80 patients, 40 with hamstring tendons and 40 with quad tendons, divided into 20 each with or without the suture tape. And the most important finding of this study was that we could show less laxity if we added a suture tape to the hamstring tendon. But there were no differences for the quad tendon. We could also show that with adding the suture tape to the hamstring graft, less patients will have a failure after 6 months with K2000 measurements of laxity. We could not see any differences in subjective outcome or strength tests. We could not see any differences in re-rupture rates or re-operations during the first 2 years. So our study indicates that if you use the suture tape with a hamstring tendon, you might get less post-operative laxity. But it's a small study and a low level of evidence. We did a power analysis based on these patients and could see that in order to have good power, we need 62 patients. So we are now started a prospective randomized study with the suture tape and the use of the hamstring tendon. If you ask yourself then, which grafts would perhaps benefit from this reinforcement? As I said, hamstring tendons have a tendency towards slacking during the rehab period, so that might be something to think about. We did a study looking at the risk factors for persistent laxity, and the risk factors in that study was young age. Having high preoperative laxity was the greatest risk factor. Use of hamstring tendon again, and resection of the medial meniscus. And then Bachmeier showed that if you have a small graft, it might be of benefit to use suture tape. Another group of patients that we know are at risk of getting persistent laxity is those with hyperextension. And I've heard from my colleagues here that you have a lot of those patients. It's not that common in Sweden. It's probably more common in this part of the world. So this might be something that you could think about. But the question remains to be answered. Another question was if suture tape reduce re-tear rates. And that's a very difficult study to do. You need well-defined inclusion criteria, consistent surgical technique, and a very large patient cohort. But we do know which patients are at risk of re-tear rates. We also did a risk factor analysis in our registry. What is risk factors for having early revision? Again, young age and very active patients. Short time from injury to surgery and early return to activity, of course. So in conclusion, biomechanics indicates protection of the graft without stress shielding. Clinical studies indicate less laxity in hamstring grafts with no adverse events and complications. And I would consider it for patients at high risk of graft failure or re-rupture. But I would say that more studies are needed, and I don't use it generally in my patients at the moment. But in certain patients with a high risk of re-rupture, if I have to use the hamstring tendon, I will talk later on the quad tendon, I might consider it. Thank you.